doctors. I welcome you all to another exciting session of No Thrombosis Workshop Series in Stroke on this digital platform. It gives me immense pleasure to introduce our course director for today's session, who is Dr. Richa Poria, sir. Sir is the HOD at the Sahyadri Hospital. And sir has set up the first neuro ICU and the neuro-intensive care of Pune. He's been a pioneer in thrombolysis treatment for stroke. He has the credit of delivering more than 300 public lectures and workshops on stroke. Sir is a member of ISA and the organizing president of the Stroke-a-thon 2012. He is the founder of the Pune Stroke Group and ex-president of Society of Neurosciences. He has been principal investigator for multiple multinational stroke trials and has been awarded as a health icon by the Times of India Group. We welcome you, sir, today. Thank you for being on board. I would then like to welcome Dr. Prem Kumar Sinha, sir. Sir is a consultant neurologist at the IB Hospital, Pune, having an experience of more than 48 years. And he has been a distinguished neurologist with a career spanning several decades. He has served as a professor at the Armed Medical College in Pune and holds a DM Neurology from prestigious AIIMS. He has made significant contributions, notably in the Stroke Center at Medior in Abu Dhabi. Sir, we welcome you. Thank you for being on board. I would then like to introduce our second moderator for today's session, who is Dr. Trilokan Srivastava, sir. Sir is working as a senior professor at Department of Neurology, SMS Medical College, Jaipur. Sir has been the executive member of ISA, executive committee member of SNVI. Sir has the credit of publications in multiple national and international journals and has been the co-author for book Differential Diagnosis in Neurology and Neurosurgery. We welcome you, sir. Thank you for being on board.
Thank you.
Then we have our distinguished speakers. The first speaker is Dr. Varun Kataria. Sir is working as a consultant neurologist at Vedanta Super Speciality Hospital, Indore. Special areas of interest for Sir include acute stroke and its management, epilepsy and epileptic surgery. He has credit of multiple publications in national and international journals. We welcome you, sir. Our next speaker is Dr. Varun Bihani, sir. Sir is working as consultant neurologist at the BLK Hospital, Delhi. He has multiple special areas of interest, including stroke, headache, multiple sclerosis. He has been awarded for multiple paper presentations at conferences. He has the credit of publications in national and international journals and has done poster and paper presentations on various national and international forums. We welcome you, sir. Thank you for being on.
Thank you, Namasha. So I will take it from here.
I would now like to hand over the session to Dr. Richa Poria, sir.
Okay.
Yeah. Thank you so much, Dr. Namra. We are having a great time on this forum. I think this is our second year, and we've discussed some absolutely fascinating cases, and I'm sure we will today also. And it is my great pleasure to welcome Dr. Trilokan Srivastava and Dr. Sinha, two very distinguished neurologists and stroke specialists, and I'm sure we'll have a great time today. Dr. Trilokan, would you like to say a few words? And Dr. Sinha also, before we start off with Dr. Varun?
Yeah, it's great pleasure to have a board on this meeting. It's the first time I'm attending the meeting. I think we should have great presentations and we should have some questions answers also.
Yes.
So,
No, we should have a lot of discussion.
Yeah.
It's always the discussion in which we learn.
Exactly.
Yeah. Dr. Sinha, so nice to see you after so many years. We can't hear you.
I think he's muted or.
Probably, sir, you would have to log out and log in again. There seems to be some software issue.
I think, Dr. Varun, we can start with your case.
Okay, sir. I'll start, sir.
Both are Varun, so we'll get a little...
it will be a little confusing, sir.
Yeah. Okay.
I hope my slides are completely visible, sir.
Yeah.
Yes. Good evening, everyone. So I'm going to discuss this case. This is a stroke in a young soldier. This was one of the tough cases that we had during my residency when I did. It was in Army Hospital, that is in Dholakua. So coming straight to the case, this was a 34-year-old male. He was a serving soldier. He was right-handed. He was posted at MH, Meerut, the military hospital in Meerut. He had no commodities. He was a resident of Delhi. And at that time, he was on his leave and he was in Delhi. He presented with weakness of the left half of the body and deviation of the face towards the right side and difficulty in speaking, which was sudden and had happened in the morning hours of 11:30 a.m. As per the history, on the same morning at around 7 o'clock, he had suffered a road traffic accident which caused a superficial cut over the right side of the neck, which had happened by the car door opening. After that, he was doing well and he did not have any complaints except for pain along the right side of the neck. And at around 11:30 in the morning, he developed the left side weakness with facial deviation and difficulty in speaking. And he was brought in a stretcher and was unable to move the left half of the body and reported to the emergency within 2 hours, but around 1:30 p.m. So there was no other preceding histories of headaches, chest pain, rash, any posting to high altitude, which we commonly have in our patients who are serving soldiers, and they could have had CVT. So it's a common history that we take, history of drug intakes, history of recurrent swelling of the legs. There was no any past history of transient attacks, transient weakness of any of the side of the body or a stroke in the past or in his family. He was in shape P1 category, that is, he had no medical background. He did not consume any alcohol. He was a non-smoker and had no high-risk behaviors. So on examination, his pulse was 80 per minute, regular with normal volume and character, and all peripheral pulses felt equally with no delays. The blood pressure was a little high, 140 by 88 with respiratory of 18 and a RBS record of 110 milligram per deciliter. There was no carotid buoy. The JVP was not raised. There were no rash or needle marks, no signs of any abnormal general physical examination. So on neurological examination, the chap was disoriented. He had a GCS of 14 with GCS of E3, V5, M6. He had a partial gaze palsy. He had a left UM facial palsy. He was able to answer questions. The power in the left side was 0 by 5. He had a mild sensory loss for pain, touch, and pressure. So on the basis of this, he was given a score of NIHSS of 14 on the basis of the consciousness, the gaze involvement, the facial involvement, the motor weakness, and the sensory and the dysarthria. And other systemic examinations, including the cardiac murmur examination, were normal. So this was the baseline CT that we had. So the challenge that we had in this case was, at that time, there are two hospitals in Delhi for the armed forces. One is the Army Hospital, which is the Apex Center, and the other is the base hospital. So the patient got shifted to the base hospital first because that was nearer to the area of injury that the patient suffered. I do not have the first base images. These are the images from the Army Hospital when the patient had undergone the CT perfusion. So the NCCT head was done, and it was done within 25 minutes. It was found that the boy had no ICH. There was a right insular ribbon sign that was seen, and a right tense MCA was seen, and an aspect score of 7 was calculated. He was thrombolized with tenective plays, had a weight of 80 kg, so a 20 milligram of IV bolus was given in the radiology department only outside with the monitoring complex after the patient had been catheterized, and IV cannulation was already done in the ER. And the boy was thrombolized within 40 minutes. Then the patient was shifted to R&R, and there the angiography and perfusion studies were done. And it was noted that on the angiography that there was a possibility of a flame-shaped possibility of dissection over the right ICA was noted, and a right MCA M1 complete cutoff was seen. The CT perfusion was seen. There was no significant mismatch as the cerebral blood volume and the flows and the MTT, they were almost equally matched. But the patient had a history that he was progressing very fast. He was clinically also deteriorating. So a DSA was done, and as per the interventionist, the DSA, it showed a complete right IC occlusion at the origin with flame-shaped configuration, which was suggestive of dissection. So this dissection flap was managed by the neurointerventionist at the R&R, and was found that the flap was crossed with the guide catheter. And after that, the cervical ICA DCA showed complete, a little sluggish flow and patchy occlusion, which was distal to the supraclinoid segment, and a complete M1 occlusion was found. So it had a cervical lesion as well as a lesion at the internal at the middle cerebral artery at the M1 at the M1 level. The thromboaspiration was done for the occlusion, after which the complete flow was achieved. It was done at 5:30 hours. It was because of the non-availability of the neurointerventionist. For the ICA dissection over the proximal ICA, the stent was placed, after which there was complete opening of the right ICA, MC, and ACA with good angiographic results. However, during the course, the patient was intubated for the procedure, and thereafter patient was kept on the ventilator, was started on high dose of statins, mannitol, and antiepileptics. He continued to become increasingly drowsy, and the pupillary response was sluggish. And on the second and first day, the check NCCT had showed no evidence of hemorrhagic conversion. However, the hypotensity in the right MC territory had there was a well-formed infarct with a midline shift that we can see, and chinking of the ventricle on the right side. And the patient underwent a decompressive hemicraniectomy with bony flap in the abdominal wall that was preserved. Post-surgically, the patient was started on DVT prophylaxis of enoxaparin, and ecosprin was also added via the Riles tube. Post-operatively, the CT had showed improvement of the mass effect and midline shift. The patient continued to be on ventilator and was subsequently shifted and weaned and put on tracheostomy. Was managed for isolated complications for VAP. Patient was worked up for cardiac causes, for vasculative, prothrombotic, and no other cause was found. So patient had gradually shown an improving course with a GCS of E4, VT, and M6. He was discharged in third week of the illness. By the time he was discharged, he was bedbound only, tracheostomised and on dual antiplatelets. He was sent on a sick leave, and once he had recovered, and after the second month, he had undergone a cranioplasty, and at third month, the chap was able to walk. If this plays, I'm not sure why is this not playing. Yeah. So this is his third month into illness. He had the upper limb power had not improved, but he was able to walk on his own. He was subsequently given he was taken out of the fieldwork and was given an administrative job thereafter. So coming to the discussion of our case, which is dissection that was found. So spontaneous dissection, it is a common cause of stroke in young, approximately 20% of these ischemic stroke patients. The extracranial component of the dissection is far more frequent than the intracranial dissections. And the neurological sequelae can occur because of three mechanisms. One is the thromboembolism, the other is the hypoperfusion, and third is the local symptoms because of the compression of the adjacent nerves and their feeding vessels. So the thrombolysis is effective and safe, and even finding of the dissection should not cause a hindrance to our patients of thinking of thrombolizing. Mechanical thrombectomy and intra-arterial thrombolysis may also be treatment options at expert centers, but should not preclude thrombolysis for otherwise eligible patients. Antithrombotic treatment, as we know, in the form of antiplatelets is far much better as compared to anticoagulations for extracranial as compared to the intracranial. Antithrombotic treatment should always be delayed until 24 hours after the thrombolytic therapy, but can be started immediately for those who are ineligible for thrombolytic therapy. So coming to the guidelines and their the conclusions as per them. So the extracranial dissections, as I said, alteplase is safe within 4.5 hours for extracranial. For intracranial, however, the evidence is unknown because of the poor vessel wall support. So they can have bleed, they can cause subarachnoid hemorrhages. And for the treatment for these, the treatment with antithrombotic should be treatment for at least 3 months. They should be treated with either of aspirin or anticoagulations, preferably aspirin or dual antiplatelets for extracranial. And if the patient continues to have recurrent strokes despite antithrombotic therapies, then they should be considered for endovascular therapies to prevent recurrence of stroke or the TIA. So for patients who are presenting with acute ischemic stroke within 4.5 hours and with aortic arch dissections, the thrombolysis is not advised because of the risk of rupture of the aortic arch. However, for isolated cervical artery disease, the risk is very low and we can undergo the intravenous thrombolysis with the alteplase. However, for intracerebral, the risk is high, so it is considered as unsafe to do thrombolysis among the intracerebral artery dissection groups. So as I suggested, the role of endovascular therapies, it is for those who have failed on your antithrombotic therapies, and these can be in the form of angioplasty, stent placements, or embolizations. Complete or excellent recovery occurs in 70 to 85% of these patients with extracranial dissections with major disabling deficits in 10 to 25%, and they may even cause death in 5 to 20% of the cases. So the learning point that I have to offer in this case is that tenecteplase was found to be safe in patients with cervical dissections. It was not associated with any hemorrhagic complications and is relatively safe. And mechanical decompression should be always offered early in young patients to have better neurological outcomes. Thank you.
Varun, lovely case. I feel absolutely right. This was a traumatic dissection, isn't it?
Yes, sir.
So, and whatever we found that hyperdense sign in MCA, that was a propagation of clot from the cervical to the MCA.
Yes, sir.
And yeah, this is one of very interesting that you attempted it at tenecteplase, but the delay in opening the things was good more than 6 hours.
Sure.
7 a.m. it happened, and therefore it landed with a stroke. But subsequently, decompression, the second message was very clear. And all over India, this will be the problem. We can't have it timely because there are very few centers we are doing interventions. Even in bigger metropolis, there are few centers. I remember in 2008, I think the first case I had, one of the patients who collapsed. Dr. Chapuria, I took it to him from Command Hospital, Pune, because he was a civilian. And he promptly did it. Next morning, he was sitting and having his breakfast. I also had about 6 thrombolysis in the last 3 months. And I find excellent responses with tenecteplase. Anyway, lovely case. Dr. Chapuria, sir.
Yeah. Dr. Trilochan, would you like to comment?
Yeah, I think it is very interesting and a very good case. And the only problem, what I think in this case, is placing a stent. because when you place a stent, you have to load with double antiplatelet. So may I ask what double antiplatelet you loaded before? Because patient are already thrombolized with 10 plates, and then you load with the double antiplatelet.
We used ecosprin and cilostazol because the patient also required DVT prophylaxis. So we used cilostazol to lower the risk of bleeding.
Okay, so you only aspirin, and what dose of aspirin you have given for
the 75 milligram of ecosprin of the aspirin and 100 milligram twice a day of cilostazol plateaus was used.
So even before placing a stent, you loaded with the antiplatelet, or just you have given only 75 mg of aspirin?
Sir, only 75 milligram was given by the interventionist. Okay. Although we had suggested to them that we have thrombolized the patient, that it is going to be risky, but they said that since when it comes to serving soldiers, the army hospital, they become that we have to offer the best possible treatment. So it was offered. So we had taken that risk, and luckily there was no hemorrhage despite being thrombolysis, despite giving extra dose of ecosprin within 24 hours.
Yeah. When you have to place a stent, you have to give antiplatelet.
Yes.
There's no other choice. And when you perform decompression after the...
So that was on almost on 36 hours, sir.
And still patient was on antiplatelet?
Yes, sir. Okay. Patient was on antiplatelets.
So yeah, managing the antiplatelet was difficult and challenging thing here, because we have to place the stent on the thrombolysis, and as well as we have to do decompression. But I think case was very well managed. Nice case.
Thank you, sir.
Yeah. Thank you, Dr. Rehani.
I feel that
few points. One is, of course, that he had a blunt trauma to the neck. And this is a very important cause of dissection. Many times we see patients who have a minor head injury, and, they flex and extend the neck due to a whiplash. And a few hours later or a day or two later, young people, they get a minor head injury and then they get a major stroke. So it's something that we must remember, that this is not spontaneous dissection. This is a traumatic dissection. And this can produce occlusion of the blood vessel and, of course, distal embolization, which is very clear in this case. The other point that I thought, this antiplatelet, we are overly worried of giving it in the first 24 hours. The guidelines have said it, but there is no trial. I mean, the guidelines said it because of safety, because people were scared that, you've given a thrombolytic agent and then within 24 hours, you are giving an antiplatelet agent. But there is no trial to show that if you give it earlier, it is harmful. There is no trial. So this is an assumption. This is an assumption. And when you do intervention, you're also giving heparin. You're also giving, and if you put in a stent, there is no doubt that you have to give dual antiplatelet. I don't know about cilostazol for stent, but we would like to use clopidogrel or even Brilinta in these cases. That is what our
usual protocol
interventionists do. And many times we have also used which is that drug? IV.
Apsiximab. Apsiximab, sir.
Yeah. So even that has been used. We've had a few hemorrhages, yes, no doubt. But many times we have to use it, especially if we put in an intracranial stent for an ICAD. So we have to use it. And we should not be overly worried. You can even give a loading dose. Why we like to give IV initially? Because the oral treatment takes about 6 to 8 hours to really kick in. So we would like to give IV first, and then pass a Ryle's tube and give the aspirin and clopidogrel or Brilinta through the Ryle's tube. So I don't think we should overly worry. Of course, there is a risk of bleeding. There is no doubt. Even without it, there is a risk of bleeding. So that is fine. So at that point, I think,
Absolutely right. I agree with you. If you look at the trial on the cardiology department, they used tenecteplase, and after that they were using dual antiplatelet. And they did have a intracranial hemorrhages, but they are comparable to what we are reporting, about 6%.
Exactly. So it does occur. As I said, it does occur, but we should not be overly worried about this, The second thing, I think you did a great job in doing because probably it is a futile recanalization. Though recanalization occurred, we would call it a futile recanalization because even though the vessel opened, a large infarct in the MCA occurred. So it became really a malignant MCA infarct. So very quickly, you did a decompressive craniectomy. I think, the way the brain swelled up and shifted, it was really frightening. He could have died on you within the next few hours. So I think you did a very good job of the decompressive craniectomy. Now, in young people, we have found what you found exactly, that, the MRSA improves to 2 or 3, but faciobrachial weakness always remains. Almost always they get the upper limb weakness and facial weakness. And if it's on the left side, they get aphasia. But that doesn't mean that you should not do it. You should do it, whether it is on the dominant side or whether it is on the non-dominant side. And they become functional. Okay, their upper limb doesn't work, but they are able to, do their ADL pretty well. And even if you improve the MRS by 1 grade, you have done a big service to the family. This chap, of course, he can't fight, but he can do an administrative job, So he can look after his family. And I think you've done a great job in him. Of course, if one has to be critical, one can say that, no, you should have opened up the vessel earlier. You took 6 hours to open. You should do it faster. This criticism can go on endlessly. But, there are
It was probably because of the issue of the transport, also because
people cannot reach. There is traffic issues. People are busy. Cath lab is busy. We have a money problem. You don't have a money problem. But we have to sort out this money issue, with the patient. And, it costs 5-7 lakhs. To do this intervention. So luckily, you didn't have this money issue, but we are constantly fighting with the family for money and, getting things mobilized. But, if you have a good stroke code and a good stroke team, you can, the only criticism in your case, I would say, is that you took a little more time. But perhaps as you become better and better and, the system becomes well-oiled, the time becomes less. So maybe you could strive for that. There's always room for improvement.
Absolutely.
Another thing is, we would have done a CT angio, of course, no doubt. But, perfusion, to do perfusion and waste that much time within the first 4.5 hours is not necessary. Actually, it's okay, to get sexy pictures and all, but but if it's after 6 hours or 8 hours or, it's delayed, then yes, of course, we would like to do perfusion and all. But in the early stage, I mean, it doesn't add value. Anyway, you have to open up the vessel. Whether that perfusion shows, no mismatch or whatever you have to open up the vessel. So maybe that maybe we wouldn't have done that. But anyway, I think overall, the end product is that he did well, and he was young. And there were learning points. You could add here that it's a traumatic dissection. Any neck trauma, head trauma, you have to get your antenna up if a stroke occurs. So he had no other risk factors. His only risk factor was that trauma to the neck. So really, it is he didn't have blood pressure, diabetes. He was not a smoker. chewing tobacco or doing anything of that sort. So it's an important thing. And it can be devastating, because the whole MCA is involved, ICA is involved, and you had that typical rat tail appearance of the ICA, which was also very classical. I think that picture, young people should fix in their mind. You have this rat tail appearance of the ICA that is typical of a dissection. So overall, I think superbly done. And mechanical decompression. Yeah. And, many times we found, in the early stages, when we were also learning, many of the surgeons were, making a very small craniectomy. So you must make a big craniectomy equal to the hand of the patient. The hand of the patient you should put on his head, and that much of the skull should be removed. And that is really effective. You do these small craniectomies. Many of our surgeons previously used to do. They were also in the learning curve, and then the brain would mushroom out, like a nuclear explosion. It would come out. So you let the brain herniate out. Let it. So a big decompression. I think that is also very, very important. The technique, and you have to open the dura. You have to do a duroplasty, because if you don't open the dura, you will not reduce the intracranial pressure. So you must make a cross incision on the dura, let the brain come out like a pregnant uterus out of the dura also, and so pressure on the brainstem goes. Another thing important for decompression: don't wait for the pupil to dilate. Sometimes these surgeons tell you, okay, no, wait. Let the pupil dilate, then I'll come. That's futile. It won't work. So don't wait for pupil to dilate. Radiological herniation predates clinical deterioration. So if the midline shift is more than 5, 7, 8 millimeter, raise the alarm signal. Because to mobilize the theater also takes another hour or so. Yeah, it takes an hour or so,
Absolutely.
And in the meantime, of course, you have to intubate, you can hyperventilate, you can give mannitol. All that is okay, but that's only temporizing. You have to do a decompressive craniectomy early on looking at the scan. Don't wait for pupils to dilate, for God's sake. Because the pupil dilates at 2 o'clock in the morning, and then the surgeon comes at 6 o'clock in the morning and does it. It's futile. So even for decompressive craniectomy, time is of the essence. In everything, time is of the essence. This concept that time is not important and only tissue is important, that's all bunk. Time is important in all aspects. Right through the entire procedure, time is important. And I think we must overemphasize this point. So a lot of learning points from this.
I also concur the same things.
Yes, Dr. Kataria.
Yeah, actually, so the one point about the small craniotomy.
Yeah.
My first thrombolized patient was a very young patient, and I lost him because at that time in 2013 when I started, it was very tough, and the surgeon did a very small craniotomy, and as you said, the brain mushroomed out, and I lost the patient.
Yeah.
So after that, I was very cautious.
Happened to all of us, Dr. Kataria. That's happened to all of us, and we've cursed ourselves, and we've had sleepless nights, and
exactly.
we were very angry with the surgeon for those to us. But then finally, so it's a learning curve. You have to learn when to do
surgeons
craniectomy,
are
how to do
learning now.
craniectomy, what post-op treatment. So you need a good ICU. You need a good neuro ICU to handle these patients. If you don't have all that, then, whatever you do, you won't get very good results. So the whole system and setup has to be there to do it. Dr. Sinha, Dr. Trilochan, would you like to say some closing remarks?
I think, yes, it is interesting and nice case. And I think the decompression is the key in this overall, because ultimately patient was saved by the decompression, not by the thrombolysis, not by the thrombectomy, but saved by the decompression. So that's the key here. Yeah.
Dr. Sinha?
Dr. Ishapur, you have rightly summed up. Either you do early or you don't do it, craniotomy. and do it wide craniotomy right when the GCS is going down. Don't wait for the pupil sign that the surgeon always will insist. Right now, pupil is okay. And don't.
Yeah. So that's an important learning point.
Yeah. Huh? The patient is having altered sensorium and is having a large malignant infarct that you can see, straight away go for decompression, because ultimately he is going to herniate. And at midnight, we are going to lose him.
Okay. Actually, first 24 hours, there is a shift of 3 millimeter also. Then you should be very cautious and you should alert.
I think anything more than 5 now, you raise the danger flag. Yeah. You raise the danger signal. Kya baba, abhi bas ho gaya. Don't waste time now. Don't waste time and don't fool around. No, wait. We'll do a scan again after 2 hours, again after 3 hours. All nonsense. Huh?
Absolutely.
Just do it. Just do it. Okay. Thanks, Dr. Rehani. We had a good discussion, I think.
Thank you, sir.
And very good illustrative case.
Sir.
Dr. Varun, can you now start?
Yes, sir. Yes, sir. So my slides are visible?
Yeah.
So my case is very short case actually, and it's a little old case also. But it's important to discuss this case on this scenario because it has some new learning things. And thanks, Dr. Rehani, for a wonderful case and the discussion. So my case is very simple. It's a 27-year-old female presented with acute onset right-sided weakness and difficulty in speaking since 6 p.m. on November 14th, 2019. And she had absolutely no other problems before that. No systemic issues, no headache, vomitings, no fever, no prior medical history or drug history, no trauma, no addiction. On examination, her pulse was 106. It was regular pulse. Blood pressure was 130 by 90. And GCS was E4 M6 V1. She was not able to speak, but she was communicating with mannerisms and limb movements. Her right shoulder and upper arm was motor power was 3 by 5 and forearm was 4 by 5. Hand grip showed mild weakness and right lower limb was 4 by 5. Score was 8. So this shows a typical presentation of acute stroke. Sometimes what happens is that there's a in young ladies we should always ask about history of their menstrual history. So this particular lady had 6 months amenorrhea, and the similar questions that came to my mind came to everybody's mind. Whether CT is safe, should I use a lead apron or should I go with MRI? Is MRI safe? Is pregnancy contraindicated for thrombolysis? And other question about the fetus and the maternal safety. So in this case, so in this case also we went we didn't do CT, we went ahead with MRI, and MRI showed the left side MCA diffusion restriction in the cortical aspect, and the flare was not showing restriction at that point. This is the flare images. So the option of thrombolysis was given, and the family were counseled, and we thrombolized her, and fortunately she did well. Next day we repeated a few sequences of MRI. Her speech started to improve, and there was a very small restriction of diffusion, small infarct seen in the left frontal area. So clinically she was better, and the right upper limb improved. Aphasia was present but was improving. So this is a very short case, and when I was counseling the patient, I was thinking about the guidelines, and during that time, there was no guidelines, and only few case reports were there of thrombolysis in ischemic stroke in pregnancy. And this case suggests that sometimes we have to take a little risk and go ahead with the thrombolysis in cases when patient has come early and it's a golden period. But as we all know that the stroke story continues here, because we need to know the cause behind it. So the routine investigations were done, including echo and everything. And one small test came positive, that was sickle test. So her HbS was 36, hemoglobin S was 36. And then after thrombolysis, we started aspirin, and then then exchange transfusion was done to bring the hemoglobin S below 30, because if we keep the hemoglobin S below 30, then Role formation and clot formation is, we can prevent that. So she underwent exchange transfusion, and then afterward, she was discharged. Then she had her baby also, and she did well. And aspirin was stopped 5 days before delivery and then restarted. Again, this was in November 2019. In August 2020, that is many months later, she again came with similar symptoms. But this time it was probably part of postpartum blues, because this time the CT, MRI absolutely all was okay. And clinically also, it was very different. So we should always follow protocol. We should always, whatever the teaching is there about the acute stroke, we should follow that, because many times patients come in time, but the presentation is very different. For example, the previous case came with trauma. So this case presented with stroke in pregnancy. One case that I thrombolized 2 weeks back presented to me after eating warfarin on the same day. So many atypical things come, but we should always follow protocol. That saves us and that saves the patient also. Thanks.
Yeah. Dr. Varun? Dr. H. sir? Hello.
Why the second MRI was done? Why this MRI is shown? Yeah, he has some. She has some symptoms for this MRI. Why the repeat imaging was done?
Varun, the question is why the repeat MRI was done. Yeah, I think they just wanted to see whether the infarct has problem.
I think it's hunger.
Yeah, it was probably done to check for whether the earlier diffusion weighted, what has happened to it, whether it got converted to flare positive or not. If it is flare positive, means the infarct has happened. If it is flare is negative, diffusion positive, means it is still salvageable tissue.
Okay.
And so maybe that's the reason. Interesting part is, yeah, even in pregnancy, where the MRI is not there and such a case comes, what would you do? Would you not do CT? The recommendation is you cover the patient well with a lead sheet, and you are exposing only to the head. And the baby who is already 6 weeks or so, the radiation is not going to damage the baby. Only thing, the marrow and this fear about the myelopathy and the neoplastic thing or the bone marrow, they are the area of concern. But the area first is the benefit to the patient who is going to so severely disabled and the life threat. So CT can be done, provided, I think, with the lead. This is one of the, somewhere we read on it. Second part is in this part of Maharashtra, Vidarbha. You find a lot of tribes and people are having sickle cell problem. And the facilities are not enough. The screening of population is still to meet the requirement. So we will keep meeting such families. So everybody in a stroke in young in this territory, we have to keep sickle cell in possibility. And so rightly has picked up. Otherwise, in pregnancy, they have also got intimal thickness in the MCA causing these kind of problem. They have recorded, I have seen some cases, but beside the coagulopathy. And one of them is the concern about homocysteine. Although they are known basically for the venous infarct, but they can come with the arterial infarct. But it was not clear. The patient had problem at 6 p.m. and after how many hours he was trying to give it. If it is within 4.5 hours, then we don't have to worry about the diffusion, weighted, and flare. These concerns are only in wake-up stroke when the time duration has already crossed the window period, and
Yes,
we
sir.
still want to give a thrombolysis.
Yes, sir.
So that was the third issue. The rest well done, very good. And sickle cell, the sickling in pregnancy is because they are fasting. They are many times not eating enough, so they are dehydrated. So they all trigger it. Right. Ichapuria, sir?
Yeah, Dr. Trilochan?
Yeah, I think it's again very interesting case and very well managed. For the sickle cell, ultimately, you follow this patient with transcranial Doppler, etc., for blood transfusion, etc., or her hemoglobin was maintained throughout in the follow-up.
In the follow-up, hemoglobin was maintained, and then after pregnancy, hydroxyurea was started.
Okay.
The screening of the baby and the husband was done. So husband was not a carrier, and baby also didn't got the gene, HBB gene. Baby also didn't get the gene.
Okay, fine.
Yeah. As Dr. Sinha very rightly said, that, this fear of doing CT scan, we can do the CT scan. We can even do mechanical thrombectomy,
yes,
if it is required in pregnancy. So yes, the fear is there of, exposing to radiation and all, but you have to save the mother. If the mother gets disabled and dies, even the child is going to get terribly this thing. So you have to look after the mother. And if you don't have an MRI, or if the MRI is going to take a long time, you can do a CT scan and you can do mechanical thrombectomy. You bear, of course, the radiation will be much more, but you should not deny mechanical thrombectomy to these patients. And, it's not in the guidelines, but, this pregnancy and giving IVT. Now, the molecule, Actilase, is a very large molecule, and it does not cross the placental barrier.
yes,
So the risk of the baby getting a hemorrhage is not there. The only risk is that, there can be a placental hemorrhage.
yes.
So, but that risk is very low. And
So, sir, if you already know that she has placenta previa, then you have to straight away go for mechanical thrombectomy. Then hydrolysis cannot be done.
Yeah. Okay. Yeah. So, yeah, but if there is no placenta previa, you can give, I think it's not in the guidelines yet, or it may be 2B, because, some years ago, we had also had this problem, and then we looked it up. There are case reports. There are, I think, 50, 60 cases of when I looked it up that time. I don't know today. Today, there may be more. But I think we can give Actilase, so definitely you can give. I don't know about tenecteplase. I'm sure you can give tenecteplase also. So we should not worry. That small risk of placental hemorrhage and abortion is there, but the baby won't get a hemorrhage in the brain or in the stomach or somewhere. So because it doesn't cross the barrier. So we should not worry about CT scan. We should not worry about not giving IVT. Of course, if it is a large vessel occlusion, you have to take for mechanical thrombectomy. That is, just treat the patient as if that pregnancy is not there, because you have to save the mother. If the mother dies, or if the mother gets a severe disability, the child will also suffer or may not even survive. So that should be the prime goal. And I think you took all those decisions superbly well, I must say. And, everyone wants to do, many people want to do, not everyone, many people want to do an MRI to see diffusion, but you don't need to see the diffusion defect. If there's a clinical radiological mismatch, you just want to see that there is no hemorrhage. And you can thrombolize. And if you do diffusion and there's no, as Dr. Sinha said, you don't need to see mismatch with flare. If it is within the window period, within 4.5 hours, don't do this flare mismatch. Whether there is mismatch, no mismatch, it does not matter. This thing has gone around, people are saying, no, I want to see the mismatch, only then I will thrombolize. That's all bunk. It is only if the time of onset is not known or if it is a wake-up stroke. Right. Otherwise, there is no requirement of doing mismatch MRI for giving thrombolysis. I don't know from where this concept has come, but it has to be buried forever.
Absolutely removed. In the hospital I worked here, somebody had put a protocol. He will do CT, then he will do MRI, then he will do.
You are wasting so much time.
You wasted the time.
Yeah.
So I said, just please remove it. I will do thrombolysis on telemedicine.
Correct.
I do there. I tell the video, take a video of the patient, raise the hands, show the teeth, talk to the patient, raise the leg, and take the history, tell me what time it happened, confirm it. Then take a CT and show it to me. All on WhatsApp.
Absolutely.
And then I will say, go ahead. And if you need, I'm here to back you and come back. And these thrombolysis have gone very well.
Absolutely.
And right, it can be done. Sometimes it is finding difficult to give it in the emergency. This tenecteplase is not available. So it's because the patient convincing is required. Give it in the ICU. You have to reduce the door to needle time.
Yes.
Very much. Don't unnecessarily prolong. Like one case thrombolized. And after that, 2 hours later, we did a MR angio. MR angio was clear. Fine. So the question came, was it a stroke? I said, look at the picture photo. Patient came, he could not talk, can't lift the hand. And now I do a MR angio after 2 or 3 hours after the thrombectomy, tenecteplase, because by the time he's shifted there and the time of the lab. So I said, don't wait to insurance to prove that why there is not block. And CT is normal, MR angio is normal. Why did you give him? Okay, show the picture to him.
No, that's absolute. You have spoken words of wisdom, Dr. Sinha. Absolute words of wisdom. I just hope that everyone follows you. Really, because all this nonsense goes on, of doing this MRI and doing it again. We don't need. Keep it simple. Keep it simple.
Radiologists, they have a concern. I will not give a contrast. Why? If I don't have a creatinine. It is especially mentioned in the guideline. You don't have to check anything else other than the blood sugar for giving thrombolysis.
Correct.
Creatinine, and unless even if he is having unless he's on renal failure, his creatinine is high. Okay, so what grade you're going to do it?
Exactly.
Actually, if patient is, even if creatinine is high, and if patient is on dialysis, you can give contrast. कुछ नहीं होने वाला,
बाद में निकाल देना dialysis.
Yeah, of course, you're doing dialysis, na?
Yeah.
You're doing dialysis. So let's not worry about doing creatinine prior to CT angio. It's all bunk. You don't need to do it.
Daytime, the radiologists are not ready to do this. It takes time. I will not.
They are wrong. They are wrong.
Most of the stroke center, they do a CT and they take a CT angio in case it's a stroke. We tell them
that is the way to.
One shoot, straight way you did. Otherwise, you give a thrombolysis and subsequently you are assessing the vascularity. Then we send for MRI neck and MRI brain, whether the major vessel, how are the peripheral vessels, how are the perfusion.
So, Dr. Kataria, in your case, you thought this stroke was due to sickle cell anemia?
So I thought about it because she never had any sickle crisis. She never had any crisis. And this was the first presentation. So initially I was in great doubt because only presentation of sickle cell in a patient coming from a good family background presenting as a stroke, I thought there must be something else also going ahead, but I couldn't find anything else.
No, pregnancy itself is a risk factor for stroke. Yes. Because in pregnancy, because of hormonal changes and blood pressure and whatever, the risk of stroke is higher in pregnancy. Now here, it is complicated by the fact that there was sickle cell trait. But sickle cell trait would not increase the risk. I may be wrong. I don't have the figures here. But sickle cell trait, does it increase the risk of stroke? Or it has to be a full-blown sickle cell anemia?
No, sickle cell trait can also increase the risk of stroke.
Okay.
If you are a little dehydrated, or you have pregnancy, or you have some other.
Okay. So it's an additional risk factor. Yeah. So you did exchange transfusion in this case. I think wonderfully managed. Very, very well managed case.
What is the present concern about? What is the present status of you talked about it, the exchange transfusion we will do to bring down sickle cell percentage like certain thing. What was that?
Yes, so
because it's an adult human being. For an adult to do transfusion, you have to transfuse at least 20-30% of a blood you will take out and will replace it with packed cell of a normal. Is it correct?
Yes. So we called a hematologist, and he suggested that even if you reduce the hemoglobin S to just below 30 also, then your chances of this thrombosis and your blood rouleau formation and its viscosity will reduce. So her HbS was 36% before exchange transfusion. So single exchange transfusion was done.
How much did you do? How much blood did you remove?
Around we removed around 15 to 20%.
15 to 20. That is how many ml? 1000 ml.
1000 ml around. Yes.
1000 ml. Yeah, because I've not encountered this type of situation. So, it's very nice to learn about exactly how to do it. So, very interesting, really very interesting.
20% of...
Dr. Trilochan, have you seen in Jaipur, is it common, sickle cell?
Not
in
our
area, it is not common. I have not encountered this thing.
Yeah, again, not very common. I've seen some children with sickle cell disease and stroke. Kids with stroke, but yes, it's not common.
Yeah.
Once
Dr. Sinha has been in the army, so he's been all over. So he must be having a rich experience with sickle cell.
Yeah, in Vidarbha, this is a big belt of people having sickle cell, and the government is looking at it that way. Even today's newspaper has talked about sickle cell. So we used to routinely do for the pediatric ward duty as an intern. We have been doing it sickle cell as a bedside, testing for the children coming with. So it was indeed a problem there. But a stroke as a sickle cell, I have not seen. I have seen sickle cell causing infarct, bone, ulcers in the foot. I have seen sickle cell crisis coming, severe pain, abdomen, spleen area. That I have seen in splenic infarct. We have seen these things. I have seen anemia could be just around 6, 7, not very severe one, and 7, 8 kind of anemia, but they come with you with pain abdomen. Recurrent pain abdomen could be one of them, and vomiting. So that was a very interesting way. See, in pregnancy, the intima of the brain, the MCA, middle cerebral artery intima, they have found it thickened in some of the cases of pregnancy and stroke. So they have no reason why it does. They say it is related to some estrogen, something at that phase, some hormonal theory they are trying to put. But they say this is one of the causes for increased stroke in pregnancy. Anyway, so how do we know it was not, it was indeed a sickle there? And how did the thrombolysis reduce opened up the sickle cell? Because sickle cell is basically a rouleau formation.
Yes.
They are the sickle cell and they produce more for an infarct in the peripheral vessels, not the major vessels, because it's a capillaries which get clogged. The normal foldability of the RBCs are affected in sickling. And so they don't fold. So there were multiple minor infarct. Even in the spleen, they don't make a huge infarct. They make a multiple micro infarct.
Yes.
So anyway, it is as per the protocol. You have done the right thing, and your patient has survived. You have found his sickling. You have done it. Wonderful. Thank you.
Thank you. I think we've had two very good cases and most wonderful discussion by everyone. So really, I am really happy, and we've learned so much. And our ideas become clearer. It's not that you learn, but you also learn subconsciously. By talking to people, seeing what they think. So I think the purpose is served with this, and I'm sure Dr. Sinha and Trilochan will also agree with this. And I'm sure they have also enjoyed today's program. Dr. Sinha.
Yeah, thank you very much, Dr. Ichapuria. We always look up to you. I think you are one of the senior gurus here in Pune. So,
yeah, Dr. Namra, can you wind up? Dr. Namra?
Yes, absolutely. Thank you, Ichapuria sir, for giving time for this meeting, and we are grateful to you for the same. Thank you, Dr. Trilochan sir and Dr. Sinha sir, for the wonderful insights throughout the case discussions. And also our eminent speakers, Dr. Varun Kataria sir and Dr. Varun Rehani sir. Thank you for the wonderful case discussions. It might have been helpful for all the attendees who are watching. So we have 521 attendees who are currently live and watching the
521 is a good number, huh?
Very good number.
अपना स्ट्रोक कॉन्फ्रेंस में नहीं रहता इतना.
सही बात है.
Anyway, I'm sure everyone has benefited, and the persons who benefit the most are the speakers. And the moderators and the other people. I'm sure the audience also benefits a lot.
Right, sir. Thank you very much, sir. Yeah. Thank you, everybody.
Thank you.
Lovely to be part of this discussion. Thank you.
Thank you.
Thank you so much.
Thank you.
Yeah, thank you. Thank you, Emcure, for being part of it and for educating us. Yeah. Thank you.
Yeah, we'll call you again.
Yeah.
Okay. Thank you.
Thank you so for being part of this meeting.
Yeah.